And I am here with, we kind of have a joint webinar today, a new planning center, and we're going to get to who that is in just a moment, and the All-In Implant Center. I guess I might as well start there with you, Dr. McRae. Thank you for joining. I spoke with him earlier. He has this massive bio. It's going to take me 45 minutes to read it. So what I'm going to do is place this in the chat once we get started. So anyone who wants to know a little bit more about Dr. McRae's background, you're free to go into the chat and just read about his history. So Dr. McRae, thanks so much for joining us today.
Thank you, Emily. It's great. It's a pleasure to be here.
Wonderful. And the next person I'll introduce here is Marius van Tonder. Basically, the concept behind a new all-in planning center. If I get this right, I'm stumbling over my words. Marius, you as well. I'm going to be placing your bio into the chat so people can read a little bit more about you and maybe understand where this crazy accent that we're going to hear from in just a second comes from. Thanks for joining us today, Marius.
Thank you. It's nice to be here.
Wonderful. Well, before I pass the time off to you, I know everybody came to listen to you. Just wanted to remind everybody of a couple of things. First and foremost, this webinar is being recorded. We want to make sure you can go back and rewatch this if you're interested in participating and doing what these guys are doing together. They came up with this amazing concept, and I've been in dentistry for over 20 years now, and I've never seen anything like this being done. I do believe it's truly revolutionary. As we continue to build our basically education library that will go on both websites, and these guys, they'll tell you more about it later. We want to make sure you have access to all the education out there that they're putting so you can participate. So it is being recorded. We'll make sure that if you participated, you get the recording about 45, well, I was going to say 48 hours after the webinar, but we'll see once we get that edited if there's any major flaws. And also I wanted to mention that we will have a Q&A session at the end of the webinar. So your questions will be typed into the question box on the control panel on the right-hand side of your screen. The questions will come directly to me and I will read them at the end of the presentation. So, sit tight. We want to get your questions. We're going to try to get through everybody's questions today. Don't hesitate to reach out and we'll make sure we get them answered hopefully before the end of the webinar. That being said, I think we're about ready to jump in here. And Marius, I believe that I'm going to pass the time off to you first and foremost, correct? And then from there, we've got a presentation from Dr. McRae that we're going to jump into. Is that kind of the plan here?
Exactly.
Perfect. Well, I will go ahead and stop sharing my camera now, and you guys can go ahead and get started. Thanks again for joining.
Thank you.
Okay, so yes, allow me, let's go to the very beginning. Where did this all start? So I was working on implant planning software and came to realize that we have the ability to extract a tooth from a model. And the result of that is to have the actual root socket in the model and to have an entire file or the crown and the root of the tooth. And I think of all the cases that I've restored in my life, implant planning or implant cases, technicians always struggle with the same old things. And, we always have the black triangles that patients complain about in the anterior. And when I saw this was possible, I thought, well, maybe we can do something with this. Maybe we can solve a problem or a couple of problems. And I did some testing, I did some dummy cases, and everything worked on a model. But then, not being a dental surgeon, I had no idea whether this is going to be possible in the mouth. Can this even be done? So I approached a couple of, what can we call them? I would call them in layman terms, a couple of big shots in the industry. And I explained to them what I want to do, and they have that expression on their face of they are completely not with me right now. And then I think maybe it's the weird accent Emily was talking about. And it was quite a bit discouraging. And then I approached Dr. McRae. And at that time, he was working on something similar. He wanted to find that solution. So I think it's a pretty much a blessing, the fact that he and I could get to each other, and since then we have done many hundreds of these cases, and the results we're seeing, I think, is truly phenomenal. And that's the reason of this webinar. We want to show you what we do. We're not here to sell a product. We just want to introduce you to what we do and and how it's done. So in future webinars, we'll be going more into the details. I think today we just really want to get the concept across. And I said earlier, I'm usually the guy with the presentation who's all nervous at this point. This is the best webinar I've ever been on. I'm just going to hand over to Dr. McRae, and then I will be the, let's call me the devil's advocate, but I'll contribute here and there. But Dr. McRae, I respect you as I think you're a brilliant dentist, and I'm grateful that you really embrace this, and yeah, it's been a pleasure, and nice working with you. So off to you, sir.
And Marius, you as well. I just have to finish that in that I was probably working on this probably just like you about the same time frame. Probably 2 years prior to that, I was trying to do this. The missing piece was the planning that I was having done for me. I wasn't getting the results I was looking for. So when and I'm going to show you how we got all introduced and how this all happened. And then we're really going to talk a lot about just kind of the philosophy and how this marriage is the thought process that we went through, and then really how close it is related to really medicine and what they're doing in medicine. So let me go ahead. I'm going to go ahead and start this this webinar. Let me share my screen, and let's see here. Make sure that I'm doing this correctly.
So far, so good.
All right, so you see my screen, and we'll go ahead and launch it. We're good?
Looks great. Yep, looks awesome.
Okay, here, I'm gonna go back. We'll start here. Okay. So we met at what's called Smile Faith, and Smile Faith is it was a implant continuum that we did in Florida, which was absolutely fantastic. We worked on vets, and we worked on all the military, active and inactive. And I'm going to tell you, it was absolutely amazing. We placed, I don't know, hundreds of implants. It was a really cool implant continuum that we did, and it was the first one that we really kind of put on. And Marius was the planner for the whole event, working with the team, and I absolutely loved it. The sad part is the state of Florida kind of shut down the process because there was a lot of publicity, and people really had a problem with some of the things, not the process of what we were doing, but I think that they felt a little threatened. But what Marius and I did is then we started working together, and this was an article that we put together. I'm going to show you some of what we did in this article. It was really cool what we did and I'm going to show you that article. But I'm going to start here. I talk to you about medical. When I was in high school, I was playing football, and I ended up having tore my knee. This is my good knee. I just want you to look at that. And this is what a good knee looks like. So this is my left knee. And I had 4 knee surgeries, and I went in about a year ago, and I had my knee looked at, and they said, you know what, that's one of the worst knees we've ever seen. It's completely flat. There's no space. And I was about ready. They literally said, you're about ready to break your femur. So I had to have a complete knee replacement. So I did a lot of research. And in that research, I came across this company, and I went to the surgeon, and they told me about this. And I just kind of want to show you what this is. I think this is really interesting. And I want you to think, as I play this video, I want you to think of this medical model and the difference between us as dentists and the medical surgeons and how they do things.
Of enhanced planning, dynamic joint balancing, and robotic arm-assisted bone preparation. These 3 core features were adapted to enable a Mako total knee procedure with triathlon. Enhanced planning. CT data is segmented to create a 3D model of the patient's bony anatomy. The Mako total knee application allows you to position the triathlon implant on your patient's virtual anatomy prior to the procedure. This patient-specific preoperative plan enables more accurate implant positioning.
So with this, I decided to use a robotic way of being able to have a total knee replacement. I want to show you is just the planning that it takes to be able to go through something like this. And it is not letting me.
You gonna play a video?
Are you there?
Yeah.
No, it's not. Okay, here we go. Okay, we're back. So let me go. I'm actually going to go back one. So if you look at this, this is the actual planning. What happens when you have a total knee done? What you have to do is you go in, you get a CBCT taken. After your CBCT is taken, then it goes to a planning center. The planning center then meets with the doctor. They go through all of the preoperative, and this is the knee, and here's my surgery. And I asked them, hey, would you record this for me? And so they're actually recording my surgery, and this is how the robotic arm works on your knee. And it's very, very precise. And that's what I was looking for. I was looking for the most precise way of being able to have this. And what you end up with is a better outcome and with less downtime. So that's what happens. And the amount of doctors that do this, the surgeons, it's only 13% in the world. Out of all of the knee surgeries, it's only 13%. So think of yourself, what is that in dentistry or in oral surgery? What is the percentage that is actually using guided surgery? I think it's that number is less. Would you agree, Marius?
Yeah, absolutely.
Yeah, I think it's more like 5 to 6%. It's really low.
I do believe it's growing, though. We're definitely seeing an increase in guided surgery cases, but I am quite amazed that so many surgeries are still not done fully guided.
And Marius, this is good. So why do you think that is?
Yeah, I've been trying to answer that question, because if you have a procedure that takes away any stress, it eliminates any surprises, shortens chair time, etc. I do not understand why you would not do guided surgery. It's just something I do not. I can even not get to a specific type of surgery that I think you should rather do guided. I do not understand. So why that is, I would not know. But I also know you showed some research a while ago how that number is different in the US compared to the world, right?
Correct.
Significantly more in the rest of the world than in the US.
I think part of it is that we are taught, and for the dentists out there, I want you to think about it. In dentistry, when we go to dental school, how are we taught? We are taught to sit in a operatory with an instructor, and you learn by yourself. In medicine, you do rotations and you do it in groups. And I think that group thought pattern is much more taught to us in the medical field than in the dental field. So we are taught to almost be loners. Do your own dental work, do your own lab work, do everything by yourself. Don't go out and don't, in a lot of ways, even don't refer. I mean, it's just one thing after another. Well, so that's, I think, part of the process. So this is the father of implant dentistry. This is Dr. Brannemark. And Dr. Brannemark, one of the things that he says is this. In 1977, osseointegration, the healing period should last 3 to 4 months without loading. So this is what was told to us. And so if you think about it, all that time, that's the majority of how implants are done. You take the tooth out, you place bone graft, you wait 3 to 4 months, then you place the implant. Then you wait another 3 to 6 months, potentially up to a year before you get osseointegration of that implant. I want you to look at this graft. This graft is very, very famous. And if you look at this, let's just say that we're going to say just osseointegration, the stability. Let's just use those numbers. Let's say we put that implant with 50 newtons torque. And if we put that in at 50, and what happens, and you take that line across in time, what happens is you have the osteoclast and osteoblast activity that takes place. And so the osteoclasts end up eating the bone, right, around your implant. And then you get osteoblast activity that builds new bone around the implant. So it takes some time, up to 2 months. And so that's why you look at this graft and you realize, okay, you can't do anything for a total of 2 months, and you can't put any pressure on that bone. So that's kind of the old way of thinking. And you can understand with this graft why that takes place. But let's look at what is implant success. And this study looked at almost 588 patients over 9 years. And what they said in this study is that 48% developed significant perioimplantitis or some sort of complication. So that's the problem, is that implants are, I mean, there's a lot of issues. And so when you look at implant failure, first of all, I have no idea how some of these things were done. I mean, this is just crazy. This is not what you want in an all-on 6. All of a sudden the patient comes and says, and hands it to you. That's a bad day. This is a PET, partial extraction therapy, that did not go well. I mean, this is pretty rough stuff here. Okay, look at this one. This is a bad day. Yeah, in the sinus, in the nasal cavity. This is not a failure. I just think that this was so interesting, I had to include it. And I just want to know how in the heck this happened. Look at this. That's quite the surgery.
Wow.
Okay, so let's look at this. This is what I would consider a phenomenal surgery. This is done by, and I got to hand it to Dr. Kim for actually putting this forward. And what I'm going to show you is, okay, let's look at this. And I want you to be really in your own mind. I want you to think to yourself, okay, what potentially could go wrong in this surgery? What did he do wrong? Or is there anything that you would do different? So really, really take a look at this and try to determine what is it that you see. Is the implant placement good? Is the how the surgery was done, the sutures that were used, anything like that? And here's the radiograph. So you can see we got good bone all the way around it. All that looks like it should absolutely be a great case. And then you look at this. And so the question was, what went wrong? And I don't know that there's any right answer. Marius, do you have any ideas?
It's a bit difficult for me to see how the implant is placed in a buccolingual direction. So we can see the mesiodistal looks nicely placed, but not sure.
So I want everybody to always think blood supply, blood supply, blood supply, blood supply. So when we flap and you remove all periosteum, this is the only thing that I saw that was wrong. And I'm going through the case one more time so that everybody gets to see it. So this is a case non-guided. It looked like it was well placed. Well, not too close to that root. Looks like it was fairly well done. Most likely, Marius, you and I would have placed that a little far more distal, a little more upright to get a better restorative, correct?
Yes.
And then if you look, here is that one film where you see the buccolingual. And so what I'm saying is that lower left picture shows a complete removal of periosteum. And my theory is don't ever flap if you don't need to. You're removing all of the blood supply. Is that the reason it failed? No one will ever know. That's the only thing that I can see potentially wrong. In fact, I did a full mouth all on 6, upper and lower today. It was a huge case, and the dental anesthesiologist said, "Do you always use guides?" And I said, "Always." And in this case, we were able to do it it was completely flapless, and it absolutely turned out great. So, but I've had plenty of failures too, and boy, do I have plenty. And I can show you lots of issues. And here's just a video of patient came in after the implant was placed, crown was on, restored everything, and was having some issues. And we saw that it had some problems. So this is just me cleaning it out. And you can notice, not a good day for me. And patient ended up losing it, had to bone graft and start all over. So what we have to do is understand that there's a difference between an implant and a tooth. And if you look at the biological width, is there a biological width on a tooth, and is there a biological width on an implant? And they are completely different. This, I think, almost makes it look like they're the same, but let's look at an actual tooth. And I want you to really, this right here should be ingrained in every one of our heads, that this is a natural tooth. So this is a slide of a natural tooth. And I have to hand it to this P. Schubach that created this, because to me, every time I do an implant, this is what I think of. So this is a tooth with the Sharpie fibers, the hemidesmosome area, and look at the organization and how well it attaches to the tooth. Now, look at this. Here is an implant. There is a huge difference. It's very fragile. And that fragile adhesion from a tooth and the attachment that it has to a implant is super fragile. And you need to make sure and let your hygienist know that it is this fragile. So when we look at a tooth and we say, okay, here's a tooth and here is an implant that just had a healing abutment, what did you do? That was a stock healing abutment. And so what do we do with that stock healing abutment? And I want us all to be honest. When we take that stock healing abutment off, we have an attachment to that stock healing abutment. And what do? We remove it to take our final impression. When we remove it, we are literally tearing all of that attachment off. Then we go put our impression coping or scan body. We scan it or take an impression. It's in for 15, maybe 30 minutes. We take that off. It's reattached to that scan body. That's tear number 2. Then we put that old healing abutment. We don't get a new stock healing abutment or custom healing abutment. We put the old one back in. We might clean it up a little, put it back in. We let it heal for 3 months while the crown is being made. Cement retain most likely, or screw retain most likely. We're hoping, but it might be cement retain. Then so after 3 weeks, we rip it again. Then we go in and we put our final in, and that's if everything goes perfect. So that's 4 attachments. They say that potentially we only have 5 rips in the lifetime of that healed site. So every time we rip, it is one less. It's actually going to heal less and less and less. So think of that when you are doing this and how fragile that is.
When you, Dr. McRae, when you talk about the rip, you're talking about the gingiva, correct?
Correct. The tissue. The tissue is always the issue. And we're going to get to that and why it's so important. Your concept, Marius, that you came up with is exactly right. And holding that tissue and why that's so important. But now let's look at the bone. And I want you to just think what type of implant this is. You know, who's the manufacturer of this implant? And think about it. You know, what kind of implant that this is. Anybody have any clues? Marius, do you know?
No, sir.
Okay, so neither do I, because it is right here. It
Okay.
is, it's in a knee. And so I want you to think with this knee, that looks like an anterior cruciate ligament repair. So in that repair, what did they do? They took a ligament, most likely it was a patellar tendon, to repair that, and they used that implant. And did they wait 2 to 3 months before they put any pressure on that? No, that they immediately got them up and started walking and started putting pressure on that implant. Now look at this one. Look at all that implant work. How soon did they get that patient up and start walking? Immediately. As soon as it was done. I had a complete knee replacement. The one thing I had to do was immediately get up and start walking. So why are we so afraid of putting any pressure on implants? What we've known is that if we can get the bone to have some pressure, not a lot, but it's some pressure, the bone heals stronger. So I was at a conference and I heard this Dr. Costa, and it got me to think about how we do things. Dr. Costa works in Dubai, and in Dubai he has this implant or this clinic called Same Day Dental Implants, and he works only on billionaires. I remember him saying that. Pretty much it's only billionaires that he sees, and so everyone wants things done same day. And so he's the one who showed this graph again to me, to the whole conference, and it really got me thinking. This is what originally we looked at, 60 days before you can even think about putting any pressure. And we've got this no-go zone between weeks really kind of 3 and 4. That is a big no-no because it's when we have the least stability. But then he re-looked at it and he said, well, what if we can look at the first 10 days? What if we can go in and we can actually restore everything? So in his clinic, all of his restorations are done in the first 10 days. They try to get it done in 7 days. They try to get stability, and then they have the patient not put hardly any pressure, soft diet for the next 2 months. So softly, and he had just incredible results. Well, I saw this study, which I think is absolutely fascinating, and they looked at what happens when we remove, let's just say, a molar. And this was only in 2023, and they looked at it and they said in the first 6 months after a tooth is removed, the average resorption is 3.79 millimeters horizontal and 1.24 millimeters vertically. So I did the math, at least I thought I did the math, and I went, okay, with that math, that averages out to roughly a total of 5 millimeters of total bone loss. And then I really thought about it and I went, okay, you're just adding the numbers. That's actually that's not correct. So what do? Do we use a calculator anymore? No, I use ChatGPT, and I literally put in all the parameters, and this is what it came up to. So the total amount of bone loss in the first 6 months of an extracted tooth is nearly 56 millimeters of cubic bone loss. I mean, think about that. We are losing in the first 6 months, even if we place an implant, and it's a lot smaller than the diameter of that area, we get almost 56 millimeters of total cubic bone loss. So, Marius, you're the one that actually showed me these slides. So would you kind of explain to them, which I think would be great if you did this, but I'm going to show the first slide, and I just want you to ask them the questions.
Okay, and you know, you really need to know what you're looking for. But when you look at this view, and you look at the gingival contour in the maxilla, you can see the interdental papillae continuously from left to right. And then when you do the same at the bottom, you can see in the first molar on the left-hand side, something happened there. So it's very clear to see that that is highly likely to be an implant crown. We can see the complete loss of the gingival contours, and we can see quite a substantial amount of buccal bone loss on that first molar. Right?
So exactly. And so when I ask people, I always ask when I'm teaching a course, I say, okay, where's the implant? And almost invariably, they always say number 10. And I'm going, no, you're missing it completely. And no one catches that lower left molar. But once your eye sees it, you can't unsee it. I mean, it's there. That bone is gone. So we're going to go through this. This is a KOL slide of another implant company. KOL means key opinion leader. So this is like they're bragging. They're showing their best work. But I want to just show you, and let's just be very honest of what we see. So the only thing that I can see, so we're going to go through this series and we're going to look at it. Why did we get all that bone loss? What happened here? So if you look at it, that buccal bone, potentially they pinched it. It might not be there, but there's some buccal bone. It's still there. So the removal of the tooth, placement of the implant, there's a lot of people that would say that's too mesial. I actually like it in that mesial route. I would have distalized that a little more towards the center of the tooth to get a better restorative component to that. But just look at that. Overall, is that good? Is it bad? In your mind, those that are watching, you make that determination of what you see. Okay, here's the healing abutment. Did a bone graft. Bone graft looks good. And we're going to look at the sutures. That's the most expensive sutures on the market. They're very good. And looks like a great technique. Potentially, they could put some PRF over the top of that. Now what we're going to look at is the healing. And is that healing good? Almost invariably, everyone says, wow, that looks great. We got a zone of attachment around that. But really look at it. And that's what we're trying to show you, is to start to get an eye for what is happening here. So that whole papilla from the mesial to the distal is completely gone. What would you say, Marius?
Yeah, absolutely, completely gone. It's difficult to see it in this view. I think it's a bit clearer, obviously, on the buccal view. But we can definitely also see that area around the implant. It's the implant was able to basically support the bone around it, if we can say it that way. But where there was nothing to support the bone, that's why we see that buccal bone loss. And this is, of course, any patient's worst nightmare. I often have doctors asking me, oh, but well, you know, why is it such a big deal in the posterior? No one can see the black triangles in the posterior, but it's a massive irritation to the patient, because that is where the food will get stuck, and it's very difficult to clean, and you constantly need to clean. But just notice how, if you follow the papillae contours or the natural contours, you can see a good couple of millimeters of gingiva is just lost. And I look at the system as use it or lose it. If we do not use it, inevitably it's going to be lost. That is, and allow me, you know, this technician really, I think he did a pretty good job. He tried his best to make it look natural. The problem is we sometimes have a molar that's 13 millimeters, sometimes even 15 millimeters wide, that needs to be restored on a 5 millimeter implant. And that's when you always end up with that mushroom effect. And one thing we never ever want is that concavity, as we can see on the distal side, because that is that's just a place where bacteria is going to accumulate. Very difficult to clean in there. But I think in general, this technician, you know, when you look at just the crown, I think he did a pretty good job.
I think it's, I mean, the aesthetics of it to match, absolutely gorgeous. And look how it matches. But what I have an issue with is there's no papilla, there's no buccal bone, there's nothing. I mean, but here's the reality. We accept this all the time. This is just what implants are. It's a mushroom on a stick, and they're going to get food that's going to compact, and we got to teach them how to clean around it. I think that's what we look at. And when you look at the bone quality, the actual healing around the implant, beautiful, absolutely beautiful. We all are searching for that. So that's a good outcome. Now we can really see that buccal bone. It's just not there. And then what's the patient have to do? For the rest of their life, use a proxy brush. They're going to have to use a water pick, something to be able to clean in between it. But patients happy because they just don't know any better. Most likely doctors don't know any better as well. So let's look at what I did is I went to Google, of course, and I said, show me images of successful implants. And this is what I got. The exact same thing over and over again. And so it's out there. We just expect when we do an implant that the tissue is not going to be as good as what it before an implant. And we tell our patients it's not as good as what God gave you originally. Is there a better way? And this is where the all-in implant, that's something that the two of us have been working and striving to do to be able to make better. And that article that I was telling you about, well, I venture to say you pick where that implant is, because there's an implant in there. Which one is it? So let's look at, in today's world of implant dentistry, there is 4 ways that I could come up with that we can do implants, placement of implants, surgical placement of implants. One, by far, let's just say 95% that are done out there are done this way, freehand. It's by far is the most common. Just like my knee surgery, what was it, 80 or 70, see, it was 13%, so 77%. 87% of all knee surgeries are done non-guided. Well, I would say 90%, let's just say 90% of all implants are done non-guided. Well, one option is this X-Guide. X-Guide has been out for quite some time. I actually got to play with it a little bit. I've talked to some clinicians that have used it. Majority of the time, they don't use it. It's just a guide that gives you a audible noise for your drill of when you potentially are away from the guide, but it doesn't actually guide anything. It's just the kind of a audible noise to tell you you're getting out of the parameters of where we had guided it. The next is, just like my knee surgery, they've got a robot for implants. I have a friend who has this. There's a lot of limitations when it comes to in the mouth using a robotic arm. I actually purchased the machine. I luckily did not take possession of it. I'm not trying to say anybody that actually uses it, but it's limited. There is a lot that has to be done for the patient. You have to actually put a lot of things in the mouth to be able to make it all work, and then you have to take a new CBCT. It's a big machine, and then it's also extremely expensive, and then every time you actually drill with it, it has a toggle, and so you have to pay on top of what you paid for the machine. Yeah. This next one is literally what I consider the very best, and that is the technology that takes place in the planning is second to none in the way that Marius does it. I'm just going to tell you that. And it is using the good old surgical guide. Surgical guide, Marius, do you know when surgical guides first came to I guess, for dental implants? What year? Give me a guess.
I would say late 70s.
Oh, very good. Late 70s, early 80s. You're dead on. So that's when the surgical guide. it's not the surgical guide, people. That is not it. The technology is in the pre-planning to be able to make the surgical guide work for us. So that is the key, making sure that everything is exactly where it needs to be. So I'm going to go quickly. We're kind of running out of time. Oh, this is a cool study, by the way. This study, they took newbies, never placed an implant. Then they took experienced doctors and they said, here's what we want you to do. We're going to give you a type it on. We want you to place the implant exactly. They gave them the parameters, and one had a surgical guide, the newbies, and the experienced doctors did not. And I'm not going to go through all of this. The key to this is that the newbies with the surgical guide was 79.41% more accurate than the experienced group. So I'm just going to tell you, if you look at it and you get in trouble and you're placing an implant in today's world, what's going to happen is if you are in your deposition and you did something that wasn't right and you had a bad outcome, here's the first question they're going to ask you. Did you use a CBCT? The second question is, did you use a surgical guide? And if you say no, then they're going to tell the judge or the jury, guess what? That surgical guide would have cost a total of $30 for the materials. That's the reality. And in today's world, in my view, it's a protection for me. So I'm going to go quickly through this one case, and then we're going to end this. We've got a lot more to be able to present. We're going to do this on subsequent webinars. But I want to show you this case because what I want to show you is basically the exact same case that we had just looked at with the KOL. So this patient comes in, she's 62 years old. Basically, that tooth number 19 has to be extracted. And so she even has a draining fistula. I mean, it's a bad scenario. And so what do? We go and we do just like we just described. We do the pre-planning. Marius does, so I take a CBCT, we take scans, we send that to Marius, also photos. We let them know, different parameters that we're looking for. And then this is what I get back. We have a 5-minute discussion on Zoom, and this is what he shows me. He shows me the position of the implant associated with the root. Anything you want to say on that, Marius?
No, I think this is just that specific view that you have there is a view that we've never had before. We can view it inside the CBCT in relation to the root, but this is always our deciding factor. Are we going to be able to load this case? Do we anticipate good primary stability? And this is a view that is just, it gives us everything. It shows us how much of the implant will be tapping into new bone and what part of the implant will be inside the existing socket. And this is always where you will always see the absolute importance of doing root sectioning so that we can preserve that septal bone, because we are very dependent in this specific case on that septal bone.
Exactly. Yep. So that's what we did. We ended up with, in this case, we had some cool surgical guides that were also made where we could, an occlusal guide, and then we had a septal bone, basically we could cut right through the furcation with this guide, 2mm guides that we were able to use. This is what we get from the lab. We have a custom healing abutment, that's the upper right. And then in this case, we were able to do a final zirconium on a tie base with a PMMA. We had that made as well, depending on the stability that we got from the implant. So here's how the surgery went. We put on the occlusal reduction guide, zipped off the top, put our 2mm guides. This is so cool. This is the brainchild of Marius as well. We were able to go right through that furcation. We knew the depth, we knew the angle, we knew exactly how to be able to go through that furcation. And so we just went right to, and he right in the drill guide, how far we needed to go. And then what do? You just take your, we took a surgical burr and we connect the dots. We took an x-ray, exactly where we need to be. remove the two pieces. The hardest part of all these surgeries is just removing the tooth. I'm telling you, by a long shot, that's the hardest part. So we take out the two pieces. We place our surgical guide. It has these marks that gives us the exact horizontal and vertical stoppage points that we need to go when for our final. We do the drill sequence, and there is that's when we need to stop. We know exactly where we are to stop. It's right in our drill report, and you can actually see it. We then measure it. We then put in our cover screw. We do our bone graft.
If you can go back to that previous picture, it's just quite amazing how similar that picture is to the case, the KOL case we looked at earlier, right?
Exactly.
Because we also placed the implant in that mesial, so it's a good comparison what the outcome of this will be compared to the one you started with. Sorry to interrupt there.
No, that's exactly right. In fact, I'm going to go back one more.
Yes.
What you look at okay, I want to show you this. Sorry, I'm going to go back. Look at that buccal bone. What did I do? I pinched it just like the other guy did. And so I messed up the buccal bone too. And so it's not there. And so look at that. Look at the buccal. But what did we do? We used the final abutment. We placed it to never be removed again. And then look at that buccal. And it's not, the tissue is not my greatest moment, because when I was taking out the mesial root, I pinched it. Here's the PMMA, day 1 of surgery. And here's the results, day 1. So this is day 1 of surgery for the x-ray. Here's 3 months. We actually got a little bit of bone growth. Pretty cool. Here's 1 week post-op. We knew we'd have a little bit of tissue reduction. 3 months post-op. Here's 3 months post-op. And then this is taking our final impression. Now, we're not going to be, I like white teeth, and so this is the final. And so here's what's interesting. Top left is the KOL, and then you can see we still have our buccal bone is still there, PDL is still there, our furcation tissue is still there. I mean, this is what we're looking for. So here's day 1 of the bone. This is after 3 years. In fact, I just saw her about a month ago, and that tissue looks great. Here's the point. Well, actually, I'm going to make the point. I'm going to go through one last thing. Okay, I'm going to really go quick with this. This is my dad. I'm going to quickly just show you. Here's the other option. We can just use a custom healing abutment. And in this case, we just used a custom healing abutment. So here is the extraction, placement of it. This is a custom healing abutment instead of a final. And what do we get when we do it this way? We get a beautiful tissue. Now look at the difference. When we use that custom healing abutment, and we put a scan body in there, we're able to capture the original tooth. Where the tissue is held is where the bone is going to be held as well. If we don't hold the tissue, we don't hold the bone. And so what do we get? Again, a little kind of too white, but it holds the tissue. And then if we hold the tissue, we hold the bone. I want to just tell you about this concept. We call it the fingerprint concept. It's what is the likelihood someone else would have a fingerprint just like you? It's actually 1 in 64 billion. It's possible, very unlikely. Let's look at a tooth. What's the likelihood that someone will have the exact same socket all the way to the apex, which Marius is able to capture? I think it's more than 1 in 64 billion. And so is it possible to be able to capture that exact socket? That's what we do. And how often do we do it? I mean, this is what we do. This is exactly what we do. And we do it every single day. This is what we want to see. And I am thrilled for our patients when we do this, because this is the results we get. About 85 to 90% less bone loss than traditional way. And the big one for me is that they are in much less pain. I'm going to stop here. I'm just going to have quite a bit more, but I just want to just share this last slide with you, and then we'll finish this up. But it was a great pleasure to be able to present this webinar to you all today. Here's our contact information. I'm going to leave that up on the screen while we answer some questions. And then our next webinar, we will continue this. And really what we're going to focus on is, how do we do this? How does this all work? And we'll show you some other really cool cases. I didn't get to the chance to show you that case that was in that article, because that really shows the accuracy of how all of this is done. Marius, anything that you'd like to add? Emily, is there some questions that we can answer?
If I may, I'm just grateful that you showed the custom healing abutment, because I do not want doctors to think that the all-in workflow is associated with immediate loading. If you do not feel comfortable with immediate loading, don't load it. If we do not see adequate primary stability, you don't have adequate torque, we are not going to load that case. Dr. McRae, just very quickly, what do you use as a deciding factor? Am I going to load this case or not? Because obviously, ideally, we want to tell the patient, listen here, you're going to come in, we're going to give you an implant, you're going to walk out with the tooth the same day, but we cannot make that commitment, right?
No, and I used to be idealistic, and I used to want to put every case and load them, but then I started having some issues, and I said, okay, I gotta pull that back. The reality is that about, I would say 85% of the time we are doing non-loaded in the posterior, and about 90% of the time we are doing final abutments in the anterior. So patients want an anterior tooth, and so we do everything we can in the anterior. It's going to take less pressure than a posterior tooth. So the other thing that we've noticed is that I showed you all of those really cool custom healing abutments around those tissue. And what I've noticed is that in the posterior, in fact, I just saw a patient today, and what does she say? She's like, hey, that little button in the back, and it's been only a week. She goes, how long is that going to stay in there? I said, no, the whole time until we're ready to restore it in about 3 to 4 months. And she literally goes, great, I love it. It almost makes me feel like I have a full tooth there. So with those custom healing abutments, here's the key. It holds the tissue, it holds the space. The patient feels the exact same dimensions of what from their tongue, and it seals the socket. It creates much less pain because there's no communication with the bone whatsoever. And then the other thing is, aesthetically, if they see white, even though it's basically right at the gum line, in their minds, that's a tooth. So you're right, Marius, 85 to 90% of the time, we're doing custom healing abutments, especially in the posterior. In the anterior, that's a whole different thing. Patients expect a tooth. And so we're doing final abutments or some sort of abutment to get them a tooth day one. And we have specific ways that we do it, but we're looking for, if I'm going to finish it with a final abutment, it has to have a torque value of 45 or greater. That's the number one key.
Nice.
Extremely insightful, Dr. McRae and Marius. And like I mentioned earlier, I hate to date myself, but I've been in the dental industry for more than 20 years, started out as a lab technician. And my understanding was that if you got an implant, you're going to have those black triangles. In fact, I worked for a very, very large dental lab, and our HR representative, and many people that I knew coming from it struggled with the black triangles, and I thought it was just a fact of life. There was no workaround from there. So to me, this is absolutely revolutionary. I think it's brilliant. I think the fact that you two found each other and we're both working on the same concept is quite interesting, because it's kind of difficult to find somebody who has the same vision as you, moving, you know, especially something that's revolutionary. There have been a lot of questions that have come in. And, you know, we try to keep these to around an hour. A couple things I wanted to mention before I jumped into questions is you may see on the screen here, Austin McRae. I know that he's somewhat runs his own lab or does some printing. Dr. McRae, do you want to expand on that just a little bit if somebody didn't have a printer?
Yes, so he does all of our surgical guides, and he does a lot of other doctors as well. So if you have, so Marius does the planning. He sends that to Austin. Austin does all of the surgical guides. He does all the PMMAs, the custom healing abutments, anything that you need from the planning side of it. He's the one that is really good about being able to do that lab work. So we wanted to just make sure that you got all of the information on this one screen. Thank you, Emma.
For sure. And if you don't have the capacity to print yourself, there's other options. There's obviously, we can work with, I think you guys can work with anybody as, you know, as they come through under different circumstances, but I think it's important to point that out. Also, I know at the very end here, we're going to wrap up with your next webinar. And I know people are going to want to hear about the next webinar topic, what's happening there. So we'll get to that. So stick around just a little bit longer to get, you know, the next webinar information that's coming up in about a month. But before we do that, there it is. Okay, there's the QR code. Scan that with your phone, and it's going to direct you directly to our next webinar's registration page. I've got the title right here because I know I'm going to say it wrong. Steps to Success with the All-In Implant System, again, featuring Dr. McRae and Marius. You know, and I think this one is going to be going into a little bit more depth regarding the planning process. So this is where Marius is going to be under a little bit more stress than Dr. McRae is this next time around. I think Dr. McRae will appreciate that. Yeah. So yeah, I think it's November 4th, about 4 weeks from now. So register, scan it with your phone. We look forward to seeing you next time. That being said, I've got a lot of questions. So we'll try to keep it kind of short, keep your questions quick. I'll direct them to whoever I think they might be directed to, but I kind of feel like a joint answer would probably benefit everybody the most. So let me jump into the questions here that have come through so far. We'll start here. Which implant system can be used for this workflow? Oh, that's a pretty heavy question right there. So
yeah, and we I'll answer part of that, and I'll let Marius, but we've used a lot of different implant systems. I'm going to tell you, number one, we've come to the conclusion, whichever is the best for the patient. That's what we use. We use a majority of the time, we're using Uris implants from True Abutment because we absolutely love them. But there's times that it might not be the perfect scenario. So for me, that's what I use. Marius, what implant systems can you do this for?
Okay, so allow me to explain why can we do it for some implant systems and why can we not do it for others? Simply because we need we need to create a library in our implant planning software. From there, it needs to go into the CAD software. We need implant companies to work with us on this. So the companies that have worked with us on this to get this established, companies who saw the value, made those libraries available to us. But then there are the implant systems that do not even know that this workflow exists. So I can tell you, Megagen, we can do it with the Megagen AnyReach and the Blue Diamond. We can do it with the BioHorizons, the Tapered Pro and the Tapered Pro Conical. We can do it with SIN from Brazil. SIN, the EpiCut 16-degree conical implants. Then we have Uris from True Abutment. And then we have Ritter. We can do it with Ritter, and we can do it with Biotech Dental. Those are the only implant systems today that we can do this workflow with, simply because we have the complete library. A lot of these components, a lot of the libraries had to be created by ourselves. It takes quite a while to get everything set up and everything fine-tuned, because we work to a pretty extreme accuracy level when we do these cases. So those are the implant systems that we can use today.
Perfect. Okay, next question. Would it be possible to do the all-in workflow without guided surgery?
No. You would have to, well, okay, I should take that back. We had a case just the other, I shouldn't say this, but we had a case that was a rush case, and literally we didn't get it planned. I'm now to the point, let me put it this way, 99.9% of the time I do everything pre-planned. This one case we didn't, and so we asked the favor of Marius, and what did he do? He was great. That morning, the patient came in, we took the CBCT. I've done thousands freehand, but now I want the precision of the guided. I don't ever want to do it non-guided. So Marius actually went in and he was able to look at the CBCT. He did the planning, and then we just talked it through. Okay, I need to angle it here. This is the depth that I was going to go. And we ended up having a really good outcome from it. But here's what I didn't have. I didn't have my final abutment. I didn't have a custom healing abutment. So can you do the whole system non-guided? No. Can you get close? You can get close, but it's never going to be as good.
I agree.
Okay, okay, I like it. Let me just read this off here. I'm realizing I should have put my glasses on. Okay, so a question right now that just came through, and I want to address this right away. Any other way to get the QR code? I am currently on my phone. Absolutely. I have your name. I will send you the webinar registration link and you will be good to go. So we'll make sure you get the registration link without a problem. So wanted to get that out there really quick. I know it's difficult when you're on a phone to then scan something. So let's go to the next question here. What kind of experience what kind of experience is recommended in implantology before I start doing all-in cases? So I think in essence, the question is how experienced do I need to be before I jump into something like this?
I think it's absolutely fantastic. If you are brand new to this, this is exactly what you need to be learning. I would say there's some opportunities that will be coming your way. We can definitely let you know that, of how to be able to get some hands-on and some practical. We're literally working on a live patient course that we're trying to finalize. But this, in my opinion, is something that every surgeon, whether you're beginning all the way to experienced, needs to be able to understand the little intricacies to be able to make this work. But this will give you the confidence, if you are new, that I never had going into my cases from the very beginning. So follow where we're going with this and what we're trying to do, and that question tells me that you get the concept, which not everybody does. Marius, what would you say to that?
Yeah, I fully agree. It's always very difficult. You know, this was something I wanted to understand. When do you qualify to call yourself an implantologist? Because there is apparently no such thing as an implantologist. There is somebody placing implants, and then you look at some implant systems, they say once you've placed 100, once you've placed 400, you can call yourself an implantologist. I've never placed an implant, fortunately not. But I do know you need to know guided surgery. As far as I'm concerned, you need to be able to place an implant via guided surgery. You need to be able to do a bone graft, and this is something, Dr. McRae, in future webinars, this is something that, you know, you can share. So there are certain things. I don't know if you're going to place your first implant in your life, if you will be able to do an all-in, if you do not know how to do the bone graft. That's just my opinion. So I think you need to know guided surgery to be able to do these cases. Do you agree?
100%. And let me just tell you, for me, I was just thinking as you were talking, I'm a general dentist. I decided to get into implants, started placing them, and I thought, okay, this is easy. Then I found out this is the hardest thing that I do, and I do well because I was having failures, I mean, more than I wanted, and I almost gave up on implants. I truly almost gave up, and I was like, I'm done. I'm not doing any more. And then I decided, you know what? I'm going to really learn. And I learned, and then I decided, hey, is there a better way? And so I started thinking about a better way of doing it, like from Dr. Costa. And then meeting Marius, it has literally taken us to new heights. I want to make sure that new doctors do not feel like the way that I felt. And I had zero confidence going into these surgeries, not sure exactly how to be able to do it. If you do it this way, you'll go in with a ton of confidence, and it's going to be the right way for you and your patients.
Brilliant.
Agree.
Okay, next question. And I know we're going a little bit over, but I'd like to try to get the questions that have been submitted answered. So sorry for a little bit over time. Is this similar to no bone loss technique?
Great question. Absolutely. It's very, very similar. Let's just put it this way. This is a pre-planning, and it's no bone loss on steroids, because it takes no bone loss, and completely with no bone loss, you're doing the same thing, except you're doing all the work free-handed, and you're not sure exactly where you're going to be placing things. And then so you do the no bone loss technique, where you're putting like a plastic disc around it. This is taking it completely a different approach and pre-planning. Just like my knee surgery with the Mako system and the robot, you are pre-planning everything so that everything is made prior to going into surgery, so it's that accurate that you can place everything day of surgery.
Yeah, the zero bone loss concept, what is Dr. Linkevicius, I believe? He's from
Yes.
Lithuania. When I listened to his one of his lectures online the first time, I thought, man, this guy's exactly on the same page as we are, but it is done in a different way. The purpose or the reason why we do it, everything is exactly the same. We're 100% like-minded. The way we do it is just, let me say, it's more digital, and it's associated with more detailed planning and designing done at the same time. And the doctor has everything chairside, even before extracting the tooth, everything is there already. That would be the only difference between the two. Zero bone loss, I don't know if there's ever any, this is just my opinion. Is there ever zero bone loss, or is there a little bit of bone loss? I believe there's always a little bit of bone loss.
We'll call it 85% less bone loss. But basically, the zero bone loss technique is making sure and holding the tissue. And if you hold the tissue, you hold the bone. That's the concept. Same with what we're doing.
Brilliant. Okay, next question. Okay, I hope I'm reading this right. Is it possible to use full titanium healing abutments and full titanium final abutments, or must it be a tie base?
Want
me to reread that? Because I will.
No, I think the question is it possible to do this with titanium? I believe definitely it's possible to do it with titanium. We can do the custom abutments. We can do the custom healing abutments with titanium. The benefit, I would say, is there's no chance of debonding. Now, when a lab does not know how to bond a restoration to a tie base properly, you are probably going to have debonding. And this is a big thing when it comes to tie base restorations. That's why many doctors are so scared of using tie bases, because of the chance of debonding. Debonding, just simply meaning the tie base is connected to the implant, the crown or the abutment separates from the tie base, and that's something we absolutely do not want. There are some materials that are better than others for bonding purposes. We're looking at materials like Graphinano, for instance, which just bonds better, but I promise you many times The lab did not sandblast it properly. The lab did not clean it properly. The lab did not cure it properly. The lab did not use a proper bonding material. So we can avoid these. To come back to the question, because I can imagine why this doctor is asking the question, because he's probably had problems with debonding, or she. Yes, it can be done with titanium. Yes, the final abutment can be done with titanium. The only reason why I love the zirconia PMMA Graphinano is the fact that it's tooth colored. If we have a bit of gingiva resorption, 0.5 millimeters of gingiva resorption, we do not have that black metal on the neck of the tooth. That to me is really the main thing. It's like Dr. McRae mentioned about the patient who asked how long is this button going to be there, because it really does look, it's the same color as or the same shade as the natural teeth. It's just not a full crown. Whenever you have something titanium there, it just looks different. But there's no reason. Titanium is well loved by bone and by gingiva. I think what we've seen, Dr. McRae, I've come to the conclusion that gingiva absolutely loves zirconia. Highly polished zirconia, not glazed. So yes. I hope I answered the question. What do you think?
The way that I look at it is that bone loves titanium and tissue loves zirconium. But to answer that question of absolutely, and there is some, especially through true abutment, they have a great ability to be able to do, I mean, phenomenal titanium milling. It's really, really good. So there's lots of opportunities to be able to use a titanium abutment, custom abutment, and there's some advantages. The biggest disadvantage, especially if you're doing the work or you're not checking your lab with a tie base, and there's, yes, the debonding. The other part is contaminants on the abutment. You have to check to make sure there's not glue that's sticking out, and you just got to make sure that it's really good, that you got a good lab, and that there's no contaminants. That's something that we hold very dear, because that is going to be under the tissue near the bone, and you don't want any contaminants.
Makes sense.
Or titanium, I don't think you'd have as much. That's the advantage.
Okay. I think I'm going to go for 2 more questions here. I think basically this next question covers a couple of questions. Oh, maybe we'll go for 3 just for sake of time. Sorry for going over, but I think that these are beneficial questions. Let's go with, do you see similar end results using the healing abutment and restoring later that you do while loading immediately? Man, I can really butcher a question.
No. I know that is a phenomenal question. And I would say, I think we get a little better results if we have enough torque to be able to go directly to the final abutment and seal it well. I think we get a little bit less resorption. And that's one of the reasons why I really try to get that done in the anterior, because I can't lose any tissue for the aesthetic purposes. Posterior, because the occlusal forces are so great in the posterior, even if I have good torque values, and what I'm talking about torque values is over 45 and under 65, in that range, maybe 70 at the most. If they're in that range, then I feel pretty confident we can go with a final abutment. There's a lot of protocols. Never the final tooth, distal tooth. It's got to have tooth on both sides of the area of the edentulous area. So there's a lot of parameters that I would want to go through with somebody that's going through this, that are going to do a final abutment. Have we had good results? We've had great results. We've also had some that we thought would be perfect, and we go, what happened? And invariably the patient completely forgot a month in, they're eating some nut or something and they heard a crack, and potentially you lost it. So long way of answering. In the anterior, that's why I try to always go to a final abutment day 1. because you get better tissue results. Little bit,
Like it.
just a little bit.
It's also the fact that you mentioned that patients don't have, or they have very little, virtually no discomfort pain. It's almost to our disadvantage if the patient
You're right.
do not have pain, because there's nothing to remind the patient that you have an implant in your mouth. So
Happens
I
a
can
lot.
get that.
Okay, next question. If a tooth is extracted and the socket is grafted without placing the implant, can we expect to see equal results regarding interdental papilla?
So if you take a tooth out, you place a bone graft, you are going to get that 56 millimeters of bone loss if you don't hold the tissue where it was supposed to, where it was originally. If you wait 4 to 6 months, you're going to have a lot of bone loss. The patient is going to feel it. They're going to be able to, you're going to have less interdental papilla, and you're going to have less interdental bone. That's just the reality. And so there's times I can't replace every tooth with an implant day one. The abscesses are just too big. So it happens with us too. And so it depends on the size of the abscess. We've also learned a very specific technique if a patient has an abscess, how to be able to remove the abscess cleanly. And there we go through a series of 7 rinses after we completely debride everything. And it's a very specific surgical protocol to be able to remove all of that, to be able to place an implant successfully day 1 of surgery. So I am of the opinion it's always best to place something in that socket that holds that tissue. And if we don't, we know that we're not going to have as good a results, but it's going to be pretty close. And we go in at month 4, the max. We want to go in month 4 because we have the least amount of bone loss that we have to deal with after that.
I think we can also answer, if I may add, we can also, in the presentation, that first KOL case, where the tooth was extracted, implant was placed, grafted, and 3 months later, whatever, the papillae collapsed. So doing a bone graft after an extraction is not enough to maintain the papillae. The only thing that's going to maintain the papillae or support the papillae is the original contours of the clinical crown, and then also together with the bone, the proximal bone that
Exactly.
because the bone and the gingiva go together, right? So we need to support it both from the inside and from the outside, if that makes any sense.
Absolutely. Very good.
Okay, so let's wrap up with this next question. This one actually is one of the first questions in, but I've saved it until now because I think this shows how impactful your presentation has been. People are interested in learning more and want to participate. How can I learn more and get started?
Marius?
Oh my goodness. We want to, this is the reason why we do these webinars. We want to be able to help doctors to learn more this way. We are working on doing, as Dr. McRae mentioned earlier, we want to get some courses going. Dr. McRae presented on this just the other day. He was in Morocco in May. So there's a lot of opportunities to hear, but I think there comes a time that you want to do the surgery and or you want to learn how to do the surgery. So I would say, you know, stay in touch with us, and we have your contact details, and when these courses come up, we will let you know. I also forgot to mention, we have some doctors from the island of St. Lucia with us this evening in the Caribbean. My apologies, I just wanted to welcome you guys, especially Dr. McRae and I will be going there, I believe, early in November. So I just wanted to mention that. Also, we have a dentist from Belize here as well, good friend of ours. Yeah, we are going to give you opportunities to just hand-on courses. Dr. McRae, I'm talking a lot now, but Dr. McRae and I created this, or we have this fantastic model that we are going to be using in some of these hands-on courses. where the teeth can be extracted, the implants can be placed, guided sinus lifts. This is also something I find doctors are really struggling with or almost scared of, how to do sinus lifts. This is also something that Dr. McRae is brilliant at. So I would say stick with us. We're going to give you those opportunities to learn more.
And if I may just interrupt really quickly, this recording will be sent to you, or basically to anyone who registered to the webinar. And at the end of it, you're going to see your phone numbers, kind of contact information, so you can reach out directly when you need guidance, you need some help. I wanted to quickly give Dr. McRae, I know a couple weekends ago, he was actually presenting to a large audience, and I know he does a lot of lecturing, kind of maybe hands-on courses. I know he's a difficult man to get a hold of. Maybe Dr. McRae, I'm speaking out of line right now. Do you have any hands-on courses coming up at this time you wanted to mention, or you know, we have our next webinar coming up in a month. Maybe that's the time to tell everybody what it is. I don't know if you have anything on the calendar now that they might be interested.
Yeah, I don't. Right now, we're working on the calendar for next year. We have nothing slated for the end of this year. It just gets really busy around the holiday season. But yes, we'll have some dates available for you. And for those that's a great starting point. Is what I'm looking to do is potentially have a hands-on portion and an over-the-shoulder on live patients. That's where we'd like to start, and then we would love to be able to work with getting you the ability to be able to work live patient, and we are searching desperately for areas to be able to do this in, and that's something that Marius and I have been working for quite some time to be able to make that happen for different doctors. And we want you to be able to feel very confident when you are going into these cases. And so you need to be able to, one, do it on a model, then be able to watch it live, and then to be able to do it yourself. That is truly the best way to be able to learn in a correct environment. There's lots of places where you can just slam a bunch of implants into patients, and that is not what we're looking for. We're looking for quality and making sure that every single patient is getting the exact implant in the right place with precision every single time.
I love that. I've heard you speak many times, both of you actually, and you guys are very strong on the patient-focused process at the very end of it. I've heard you both say there's a patient, and sometimes I think it sounds funny, but it's easy to forget. It's a process, it's an implant, it's a bone. You guys are very, very, very focused on knowing that this is somebody's life. You're working on a patient, you're going to make this good for that patient. And I love that concept. So that being said, I just want to once again mention your next webinar coming up November 4th. Again, anyone who registered, will send the registration link out to Steps to Success with the All-In Implant System, featuring Dr. Lon McRae and Marius. So if you want to learn more, please register for that webinar. And yeah, we're going to continue this series. We look forward to hearing from you. If you have questions, if you have topics you want to learn more about, respond to the email that was sent to you when you got your registration link. We'll make sure that we address all of those. So again, Dr. McRae, Marius, thank you so much for your time today.
It was a pleasure.
Very informative, very enjoyable, and we're looking forward to the next session. So thanks again. And everybody who tuned in, you know, we've got several countries involved here. That's kind of exciting. So thanks for tuning in.
Thank you. See you next time.
We'll see everyone next time. Bye-bye. Thanks again.
Goodbye.